Hello, everyone. I'm Lauren May, Director of Research at the Marfan Foundation. Thank you for joining our global virtual conference brought to you by the Marfan Foundation and its divisions, the VEDS Movement and the Loeys-Dietz Syndrome Foundation. My colleague, Dr. Josephine Grima, Chief Science Officer at the Marfan Foundation, is backstage ensuring everything runs smoothly for us. As a reminder, this session is being recorded. Please select the Q&A tab on your screen to submit your questions anytime during today's talk, and we'll cover as many as possible at the end of the session. Please reserve the chat feature for connecting with fellow attendees. Any questions that you post in the chat might get missed. We are thrilled to have with us Dr. Siddharth Prakash, Associate Professor of Medical Genetics at UT Health Houston and Chair of the GenTAC Alliance's Collaborative Clinical Science Working Group. Dr. Prakash's session title is Staying Healthy and Exercising Safely. Dr. Prakash?
Thank you, Lauren, and thanks to Joe and Michael and everyone in the Marfan Foundation for giving me this opportunity. I will go over some recent work that we've done on exercise. Can you see my screen now?
I can see your screen, yes.
All right. And can you see my presentation mode?
I am seeing what looks like, yes, I'm seeing your presentation mode.
Is it advancing?
It is advancing.
All right.
We are all set. Thank you, Dr. Prakash.
Sure, no problem. Let me start over with a brief summary for those of you who are just joining. I'm going to be talking about exercise safety and the effectiveness of exercise for people with thoracic aortic disease. And I'd like to present a little bit of work based upon our clinical experience at the University of Texas at Houston. One of this work was motivated by questions from patients like the people in the audience today. And one of the chief questions was about the safety of exercise. So I'll present a little bit of data about what we know in terms of exercise safety, and then some data on how we can expect exercise to affect people with thoracic aortic disease. And I mentioned briefly that exercise is often difficult to consider after the mental and physical tolls related to thoracic aortic disease. Both of these can lead to inhibition of activities. People are not confident to re-engage in activities that they might have done before. And I'll show you some data about this as well. So we have a dilemma, both as patients and clinicians, about advising what exercise might be safe and how to resume exercise, especially if there's been a pause after an aortic event. And typically the guidelines that we are familiar with have emphasized the importance of low impact, primarily aerobic and recreational activities, because of this sense that more vigorous activities might be dangerous for reasons related to aortic dissection. However, we know that exercise at the same time has many benefits for people with all types of cardiovascular disease. So how do we balance these competing concerns? The reasons to recommend exercise are that it can lower blood pressure. It's one of the most important ways that you can maintain low blood pressure, particularly if you have a history of hypertension. It improves fitness and endurance. We know that all types of exercise compared to less exercise reduce mortality and increase the quality of life, no matter which population you might be looking at, how old or how young. It also improves mental health, increases confidence, and reduces anxiety to perform activity. All of these things are great reasons to recommend an exercise prescription for anyone with cardiovascular conditions of all types. We know that anecdotal reports have linked some types of exercise, primarily heavy weightlifting, with aortic dissection. As I mentioned, there isn't a lot of evidence about the safety of exercise. So we can't be sure that exercise is safe for everyone. Is it always true? Can we be confident in those recommendations? We know that exercise can, in some cases, increase blood pressure, and we've been told that blood pressure is extremely important to prevent, to keep it low, to prevent aortic events. And therefore, there's a lot of anxiety and uncertainty about these kinds of questions. So this is an excerpt from one of the most recent scientific statements on exercise, that low static or low intensity activities are generally recommended for people who have any history of aortic disease or dilation or dissection. And this applies very broadly to almost everyone who might be affected by aortic disease. So traditionally, that is what we have stuck with in our recommendations. However, we know that people have difficulty re-engaging in exercise because access to things like rehabilitation services in the United States is quite limited. This recent article suggested that only about 1 in 4 people who are eligible to complete some type of rehabilitation after cardiovascular surgery actually reach that. And that's due to cost, insurance, and physical access to facilities that can be hundreds of miles away. So this is a major problem, especially when people are debilitated after an aortic dissection. And we also know that not all exercise is created equal. So it may not make sense to put a blanket ban on certain types of activities. For example, blood pressure responds differently to different types of exercise. For aerobic or cardiovascular activities, blood pressure tends to increase gradually, plateaus when you reach a steady state level of activity, and then falls off relatively quickly when you stop exercising. However, the dynamic or isotonic exercises where you're contracting with movement tend to cause a modest increase in blood pressure because vasodilation tends to counteract any increase in resistance. The most concerning kind of exercise for people with aortic disease has been static or isometric exercise. That is a contraction of muscles when you're not moving your body. This can lead to a larger increase in blood pressure, particularly when you hold your breath and at the same time strain. And blood pressures up to 300 millimeters of mercury have been recorded in heavy weightlifters. This is due to the increase in resistance to blood flow by contracting muscles with higher cardiac output due to the activity. And these changes can be less predictable. So these are the things that we generally counsel patients to avoid. And of course, no matter which kind of exercise you're doing, intensity definitely matters. So low intensity is going to lead to smaller changes in blood pressure than higher intensity. And at high intensities to the point of exhaustion, the changes also become less predictable. So we generally counsel people to maintain a safe margin between their upper limit of activities and their point of exhaustion. So this chart has traditionally been used to kind of break down sports activities by the intensity. On the left side, you can see a static component. That is the contraction of muscles that are required to do the activity. And on the bottom, going across left to right, you can see the dynamic component. That's the amount of movement that the sport requires. So generally, on the patients with thoracic aortic disease had been confined to the lower left corner. Things like bowling, cricket, curling, golf, riflery, and yoga. Notice I wrote in sex because that is a very common question. It's how much activity does sex require? It is considered safe by these guidelines. However, there are many people who wish to do these other things in the right upper corner, and we don't really have any evidence indicated by the arrows about how blood pressure responds to these activities and how safe they might be. So we do have some data coming out. These are observational studies of people who survived dissections, both in IRAD and in Europe, showing that if you are supervised during cardiac rehab after an aortic dissection, you can exercise safely. There weren't any adverse outcomes in this group. They generally did well. Their blood pressure actually got lower, and there were associations with improved quality of life. This was a short-term study, and it didn't really follow patients who are exercising at home. And there's no data on the specific types of exercises or long-term impacts of exercise after aortic dissection, and no randomized controlled trials. So we started by doing some surveys. We wanted to know if people are participating in competitive athletics after aortic dissection, and we designed some survey questions and submitted them to different Facebook social media groups of people with aortic disease, asking them about the type and number of competitive athletic events that they had participated in, both before and after aortic dissection, and the ways that they trained for the events. We also asked them if they had any adverse outcomes related to participation in sports activities, such as requiring hospitalization, additional medications, or even surgery. And so we distributed the survey to the aortic athletes Facebook group and the cardiac athletes Facebook group. You can see the numbers there of total participants in those groups. These were kind of the rough outcomes. We got 77 surveys returned. This is new data that we are just publishing now. So you can see the mixture of type A primarily, but type B or both dissections. You can see that many individuals had aortic aneurysms that were actively being followed during this period. When we asked, most of them were on beta blockers or angiotensin receptor blockers to prevent aortic dissection. And the median years since their dissection or aneurysm diagnosis was 3 to 3.5 years. You can see it's a relatively young group. Many of them were less than 50 years old. So these were the activities that they endorsed. And again, we define competitive activities as any timed or official event with other competitors. So running, you can see, was the most common one. Similarly, Ironman or other endurance activities, and cycling. But there were a variety of other competitive activities that people were doing. And they ran really the gamut of anything that you could think of. We had skydiving, we had skiing. So people are out there doing these events, and we wanted to know if they had any outcomes. We also asked them if they changed the number of events they were doing before and after dissection. So the blue bars are the number that they said they participated in the 5 years prior to their diagnosis. The orange bars are the number in the 5 years after their diagnosis, and then the total number in green. And you can see that there's a trend looking at the blue versus orange of decreasing events after dissection, as you might imagine, with very few doing multiple events afterwards. So when we asked them about any symptomatic episodes that occurred while training and participating in competitive events, 8 of our 77 respondents reported at least one symptomatic episode. The most common occurred during running, but you can see these other activities also were reported. And the most common event was syncope or pre-syncope, and this is related to lightheadedness or dizziness, both during or after the event when training. There were a couple serious adverse events. You can see there were 2 episodes of arrhythmias. I think there were atrial fibrillation, and then 1 chest pain requiring emergent hospitalization. Fortunately, no dissections, no ruptures, no deaths. It turned out the chest pain was a false alarm. So no dissections or urgent operations in the group, but there were these episodes, some of which required hospitalization. And when we looked at the main predictor of who was having these episodes, it was linearly correlated with the number of CV medications. That might indicate that the severity of the disease was greater in this group that had the symptomatic events, or it could mean that the medications themselves had something to do with the events. We weren't able to determine that. And again, most of these events were passing out or feeling lightheaded or dizzy. So the summary of that was that there was a significant decline in competitive sports participation. There were significant numbers of individuals, primarily runners, and who experienced adverse health episodes related to participation, but no serious adverse events or deaths. And we also showed that the individuals who did more regular activities were less likely to have symptomatic events. And so this maybe some of these events could be reduced by increased conditioning or weekly exercise time and strategic use of or modifications of cardiovascular medications. So this is just when looking at the people who had an event versus those that did not have any sort of episode related to competition, the training times were greater in the people who did not have any sort of problems with competitive activities. Again, showing that exercise itself doesn't seem to be the issue here. In fact, it may ameliorate, a regular exercise may ameliorate some adverse reactions to competitive or higher intensity events. So in a recent John Ritter Foundation survey, most people said that that exercise was a priority and that they were confused or uncertain about exercise. Only about half were compliant with the current weekly activity recommendations, which is about 150 minutes of moderate intensity aerobic activities per week. And the majority said that some sort of coaching would be helpful to guide them on what would be the best way to proceed with exercise. So we designed an exercise circuit to test the safety of exercise for patients initially in our clinic and then in a randomized trial. I'll go through the exercises that we use briefly, but I want to explain the rationale here. We wanted to design an exercise circuit that anyone could do at home with cheap equipment or equipment that could be mailed to them, and that we could use to get reproducible blood pressure measurements during the exercise. The reason we wanted to do this is because there was a lot of uncertainty about how people with thoracic aortic disease might respond to regular exercise. We wanted to be able to measure their blood pressure, and we wanted to be able to teach them virtually if we needed to for home-based exercise. So the goal was to do these 6 exercises, about 2 minutes per exercise, maintain a steady state of low to moderate level intensity, and then to measure blood pressure at least once during exercise and once between exercises. We would do this circuit in our cardiac rehab facility next to the aortopathy clinic initially to test whether this was feasible for people to do and watch them while they did it. And this enabled us to get an idea of how to coach people in terms of what they were able to do and making sure that they were following a low impact design. You can see we had a mixture of isotonic, isometric, and aerobic activities. The only thing that we required at the end was a bicycle and/or treadmill because we wanted to be able to compare their results to other people who were doing treadmill exercises in the same facility. So this was the study that we did initially. We got their height, weight, medications, and weekly activity levels by survey. We asked them how many minutes of exercise they were getting at baseline. We measured their blood pressure using an ambulatory blood pressure monitor, and these were the exercises we had them do: curls, we had them do leg raises, a dynamometer grip where we asked them to squeeze as hard as they could, and then we did 2/3 of that. We asked them to hold that level while we measured their blood pressure in the other arm. Wall sits, and then we had the stationary bike or the treadmill. Initially, we asked them to choose one or the other depending on their physical capabilities. So what we did was initially is just to see if there was any difference in blood pressure response in our thoracic aortic disease cohort from the clinic versus healthy controls. We got age and sex matched controls, and we just looked at their maximum change in blood pressure during these exercises. And as you might expect, the wall sit was the highest. That's where you are doing isometric contractions of your abdominal muscles, and it generally causes the greatest change in blood pressure. But the most important take home here was that there was no statistical difference between the thoracic aortic disease patients and the healthy controls in terms of blood pressure change. So that was reassuring. We also looked at the individuals who did have higher changes, and we correlated very neatly with the amount of minutes that they said that they exercised every week. So if you notice on the bottom left, individuals who developed a systolic blood pressure more than 180 millimeters of mercury during any of our exercises all had less than 1 hour per day of exercise. So anyone who exercised at least 1 hour per day on average or more did not have any severe hypertensive responses during these exercises. Again, suggesting that regular exercise actually prevents serious adverse events to exercise. And the one thing that we did notice that was different between thoracic aortic disease cases and controls was recovery after exercise. You could see that their blood pressure dropped more rapidly, and sometimes this was associated with lightheadedness. And that goes back to the adverse events that I talked about in our survey of athletes who also reported these kinds of issues. And we do think that's something to be aware of. If you're on a lot of blood pressure medications in particular, your blood pressure may not recover in the same way as a healthy person. And so you may need to give yourself some time to wind down your activities or to adjust for this kind of sudden drop in blood pressure so that you don't pass out or hurt yourself. So we did show that individuals with thoracic aortic disease were able to safely exercise. That was a big take home, but we wanted to know more. That was, can this actually be beneficial in individuals who have thoracic aortic disease? So that was the rationale for a randomized clinical trial, which is wrapping up this year. The goal here was really to determine how exercise affects blood pressure and mental health in people with thoracic aortic disease. And we wanted to do it randomized so we could really understand how the changes would affect people who are otherwise being cared for in a thoracic aortic clinic. The objectives were to rate their self-reported levels of activities and mental health, measure their blood pressure over the duration of the exercise program, and also understand how much time they were using for exercise during the year-long study. It was a multi-center trial with 3 enrollment sites in Michigan, St. Louis, and here in Houston. And the criteria for enrollment were you had to have had an aortic dissection at least 3 months prior to the enrollment, and you had to be able to attend 2 in-person sessions, 1 at each end of the study. We had a bunch of exclusion criteria, which basically meant you had to be stable in order to participate in this randomized trial. And for this particular study, they had to be able to come in for a visit because we wanted to check their exercise technique and the safety of exercise. And they had to be able to access a treadmill or a bicycle at home or at a gym. So these were the major exclusions that took most people out of the study who were excluded. So again, the goal was really blood pressure, mental health, and safety. This was the study trial design that we started last year. So at enrollment, they answered questionnaires about their lifestyle and exercise habits. We measured a 24-hour ambulatory blood pressure. We then randomized them to either the guided exercise arm or usual care. In the usual care group, we did everything that we normally do to take care of patients with aortic disease. We gave them an exercise pamphlet, we counseled them, but we didn't do any special training. And then after 1 year, we followed up both of them to repeat the process and understand how these elements, mental health and blood pressure, changed. So we used the 24-hour ambulatory monitor because we wanted to get additional information about their exercise. And we also, in our site, looked at central arterial waveform analysis, which is a way of looking at the stiffness of the aorta, because we thought that might change. This is the trial timeline. It's scheduled to wrap up in October. And you can see that we've done most of the follow-up now. We're in the data analysis phase. And the goal was to follow them up in the guided exercise group at 1, 3, 6, and 9 months with virtual study visits from home. And we would ask them to do the same exercise circuit that I showed you. At the beginning, we monitored them in person, but then we followed up with them by video to make sure they were doing the exercises and answered any questions. So this is a summary of the first 81 participants that we recently published, just to show you that we had a fairly diverse group. Most of them were on medications, and the mean time since the dissections were 3 to 4 years for all of the groups, primarily type A, but some type B dissections. When we looked at the change or the characteristics of individuals by whether they had surgery or not, you could see we had some individuals with stents, some with open surgeries, and some with no interventions at all. And so it does represent a broad group of thoracic aortic disease patients. So this is our observations. We had to screen 445 individuals. We found that 250 were eligible, and only about 100 ended up completing the study. And again, the major reason why is that you had to attend these in-person study visits. The reason for that is because we had to establish the safety of this exercise protocol that was going to be done for a year. And so we had a rigorous entry criteria to make sure that people were understanding and aware of the situation. And again, the major reasons why people excluded were that they weren't able to attend the visits or access the exercise equipment, and many were not able to meet the physical requirements to do all 6 exercises that I showed. We did show that we used a mental health inventory called PROMIS, the PROMIS scale, and we showed that their scores for anxiety, chronic pain, and impairment of participation in social activities were all mildly increased, which is what we expected at the beginning of the study, based on previous data. We did, however, show that their sleep disturbance, fatigue, and depression scores were within population norms. Everyone that we tested did complete the exercise protocol after the initial vetting session. There were no serious clinical adverse events. We had one in-person session that we temporarily had to stop when the patient showed up hypertensive. The person was very hypertensive. We sent him back to his cardiologist, and he was able to get his medications adjusted and eventually complete protocol. That was the most serious adverse event that we included. There were no dissections. Nobody reported that their aortic growth had changed. Nobody needed surgery. The exercises that most frequently caused high blood pressure in our group were bicep curls, wall sits, as I mentioned before, the stationary cycling, and the treadmill, typically because they were very vigorous for some people who had been sedentary prior to the trial. And a very similar situation for the diastolic blood pressure, which we track separately. So this is basic. When we looked at the characteristics of the 24-hour blood pressure, what we saw was that the individuals who did develop high blood pressure during exercise all had high blood pressure during the 24-hour monitoring period. And interestingly enough, fewer than half of these would have been picked up if we measured their blood pressure in clinic, suggesting that 24-hour blood pressure is a great way to determine if people are ready to start exercising. And this also shows when we looked by whether or not people had surgery or a stent, there was no change in their blood pressure response to exercise, showing that even after surgery, exercise can be relatively safe for individuals in these groups. So our endpoints, as I mentioned, we had initial high scores and for anxiety, chronic pain, and we're hoping that these go down in individuals in the guided exercise groups. After we walk them through the exercises in the session, most people reported increased confidence to exercise. We again showed that the moderate intensity guided exercises were safe. And in the first 3 months, grip strength improved by more than 20% in our guided exercise group, which is very significant and suggests that strength training was very beneficial to this group. We did show that ambulatory blood pressures were frequently abnormal and predicted high blood pressure during exercise in our TAD group. So that is promising as a way to screen patients and adjust their medications prior to exercise to maintain safety. And then we also showed that these were better than clinic blood pressures to kind of risk stratify patients. Finally, we used something called Borg effort scores, which are very easy. They're the patient's own rating of their exercise, where 1 is minimal activity and 10 is the hardest exercise you can imagine doing. And Borg scores reliably predicted changes in blood pressure, meaning that if you use this in your own activities, you can probably learn to stay within a safe zone. Again, the trial ends in October and we'll have the full results then. The next steps really here are based on this. We want to make this into a 100% home-based exercise protocol where we're simply following patients virtually and providing virtual coaching. We want to do it with licensed exercise professionals and physical therapists rather than our exercise team. As motivated as we're not the same. And we think people need that kind of one-on-one feedback because it did have very significant effects on their confidence to engage in exercise. We want to focus on people who we've previously been unable to reach, people who can't come to clinic or can't make it to a rehab facility because those are the ones where we think the exercise will do the most good. And ultimately, we really want to use these findings to support national payers like Medicare and Medicaid to cover exercise so that insurance does not become a limiting factor for a lot of people. I'd like to thank our team. I'm really appreciative of our group at University of Texas at Houston, particularly Kayla House. Kayla is leaving us next week, but she's instrumental in running the trial, and I couldn't have done it without her. Our other teammates, Yasmin Toy and Deepika Bhatia, and my colleagues at WashU and University of Michigan who have helped with this work, Dr. Alan Braverman and Dr. Kim Eagle in particular have been instrumental. And if you're interested in participating in our next trial, I've got a QR code with some questions that you can answer. We'll put you on the list, and we're working on it right now. Thank you very much.
I would like to thank Dr. Prakash for his excellent presentation today. We'll leave the, oh, I was going to say we can leave the QR code up, but you know what? We'll put the link into the chat if
Sorry
we
about
can. Dr. Greenman, no problem. We'll cover it. So members of our audience have submitted several questions, and we'll go through those now. First question, I have a genetic aortic condition and also happen to be a physical therapist. Are there currently any treatment guidelines or summaries for PTs to utilize when working with the TAD patient population?
Oh, this is so excellent. We've been reaching out to physical therapists for their opinions about this because it's very important to engage. And often our patients tell us it's very hard to find a physical therapist that will even agree to work with them because there's a lot of fear and misunderstanding out there. So if you're motivated, please get in touch with me. I'd love to make something that we could use as a resource to educate the physical therapy community. It's so important for our patients to feel confident in their providers too, and their providers give them evidence-based data. I'm happy to help with that.
Excellent. And I know this person, so I can make a behind-the-scenes connection. I really appreciate that, Dr. Prakash.
Sure.
This is a recurring theme. So there seems to be a lot of guidance around pre-surgery. What about post-surgery? Does surgery significantly reduce the likelihood of adverse events?
Yes. So what we know is that after surgery, you can lose as much as 20% of your muscle mass and an equivalent amount of your lung capacity. Lung capacity is not talked about often enough because of the particular challenges that many of our patients face. I'm thinking about Marfan syndrome, where you have chest wall deformities. A lot of times these patients, have limited lung capacity to begin with. And then when you get a sternotomy, as you know, your lung capacity can be further decreased. This can really limit your exercise ability coming out of surgery. And it does require intensive rehabilitation to get that back. Many people don't realize that it takes 6 to 12 months to get of activity to get back to where you were prior to surgery. And as we know from surveys, a lot of people aren't active to begin with. So they're already starting from a place where maybe their cardiovascular health isn't the greatest. And then you're asking them to try to strain to get back to that point. It can be very overwhelming. And that's why these sorts of programs need to be supervised and monitored, and people need to have feedback so that they can, it's a long road and they need help.
Thank you. We have a couple questions about the work that you presented. So when looking at the AD questionnaire for the athletes, were these athletes that were diagnosed with a genetic aortic or vascular condition or any aortic dissection event?
Any aortic dissection, we unfortunately, in our survey, we did not ask about their genetic diagnosis. We realized that too late. It was already sent out. But we didn't want to restrict it to that because we wanted to get as many answers as possible. Obviously, that's the only way to do it. So I can't say, we hope that the results are broadly applicable. But again, it was a Facebook group, so people who are highly motivated may not reflect, it's important to think that may not reflect the entire community. It's just the group that we were able to access.
Sure. And then another question, someone asked to ask for you to speak a little bit more about medication timing around exercise.
Yes. So there are two issues here that often come up. One is, can I time my exercise so that the peak of my blood pressure doesn't peak as high as it would otherwise? That has so many factors to it that it really is an individual question. So it depends on like what medications you're on, when you're taking your medications, when you're trying to exercise, what kind of exercise you're doing. So it's virtually impossible to answer that without doing a one-on-one consultation, which is what I recommend anybody who's serious about exercise to do, because you want to ask those very specific questions to your provider. And hopefully you should be getting answers to those questions. If you don't have a good idea of what to do, then we often need to get more data. We need to know what your blood pressure is doing. So that's why I try to get 24-hour ambulatory blood pressures on as many of my patients as possible so we can kind of predict those trends. Nothing is 100%, but it gives us some confidence about how we would time the medications, for example.
Got it. Thank you. Lots of questions around specific exercises, if you're willing.
I'll
Uh,
try.
okay. First one, for individuals with VEDS, abdominal movement-based exercises like crunches, mountain climbers, things like that. If folks are able to breathe through the exercise, is that considered still potentially unsafe?
So the answer depends upon the status of your vascular disease. If someone has an abdominal dissection, visceral dissection, for example, splenic artery or renal artery, or then especially if it's acute, we would tell them not to do those exercises because that could be a very risky situation. If there's a new tear, the artery may be considered to be unstable. That's one of the reasons we ask people to wait at least 3 months after an acute dissection to start our clinical trial. So the timing definitely affects things. The location of the dissection would affect things. On the other hand, if you've been very stable and your dissection was 5 years ago and it's not been changing and you're not having any symptoms, it may be reasonable to start low-level activities. Again, you want to start low impact and work your way up gradually. Breathing is part of the solution, but it's not the only solution. Intensity matters, number of reps matter, and not exercising until you can't do another rep also matters.
Okay, thank you. For someone with VEDS and POTS, it's very hard to exercise with both conditions. Do you have recommendations on activities that might work?
Yeah, so with POTS, you have to avoid sudden changes in position, particularly lying to standing. It can be very difficult if you do vigorous exercise. People frequently do report lightheadedness or dizziness. So one of the reasons we designed our exercise circuit the way we did is because it doesn't require a lot of positional changes during the exercise. You can do like leg lifts and be relatively immobile on the floor. You can still get quite a good workout. And so that would be one example of an exercise that would be safe for somebody who might have a lot of positional dizziness or orthostasis, as we call it. So there are ways to adapt your exercise routine. Another, I'd strongly recommend not, to avoid a lot of heat. Exposure to heat makes things worse. So, in these days, it might be important to, if you're going to exercise outside, either do it in the pool or do it early in the morning or late at night when you're not in the direct sun. And of course, avoid a lot of fluid loss. You need to stay hydrated because that will definitely make things even worse.
Thank you.
Sure.
For someone whose 15-year-old son does not have any cardiac issues, it does not specify their actual diagnosis. Would it be okay to play a sport like volleyball?
So the answer is we really need to do a complete evaluation. I'm assuming that had happened. If the evaluation shows that there's no blood vessel disease and normal heart function, then in most cases, the question becomes, is there a lot of collision related to the sport? There are other risks besides blood vessel risks with VEDS and related conditions. You can get muscle tears, ligament tears. So if it's a vigorous activity, then those risks will be increased regardless of whether or not we think it's safe for the heart or blood vessels. And that needs to go into the counseling about this. It usually requires a lot of knowledge of both their orthopedic history, that they have any previous injuries, and then as well as their vascular history and imaging. So I always say it's got to be a very detailed, informed consultation before we can make any decisions about an individual.
Along similar lines, someone wrote in saying that they understand the urgency of the cardiac and aortic aspects tied to exercise. Are others researching risks to the other body systems? So this, are spinal issues, ribs, feet, things like that you're aware of?
Yeah, that's great. So I know that some other exercise studies have involved discussions about athlete injuries. We didn't limit our survey, for example, of the dissection groups to just cardiovascular events. We asked them, have there been any major health events? And nobody reported a serious injury. Now, this is a selected group. They're probably more active than usual. So you would expect some injuries to occur even in a healthy population. And we just don't have the data on how much more likely it is based on the type of activity. It would require a larger sample size, unfortunately, because we need to get dozens of people in each activity type in order to normalize that and know what the baseline expected rate would be. So I don't have that data. And I'm not aware that anyone has done a study with that magnitude in order to answer the question.
Okay. Someone wrote in that they are a year and a half post-dissection and always tired. They try to walk 30 minutes a day, but then they're seeing others post-dissection who are able to do more, and they're wondering if there's something that might not be right with them. What would be your recommended course of action for them?
Okay, so fatigue and decreased exercise are really common after dissection or surgery. It will happen to everyone. So the first thing is to realize that you are not alone. The second is that if things are not improving, it's important to rule out medical causes first, because those are usually correctable if they're diagnosed. And fatigue is a very common symptom. So there could be many medical causes. An example of a common cause would be medications. So in many cases, after dissection or surgery, your medications might change. That can be enough to cause new side effects that you haven't had before. And one of the main side effects is fatigue. So there are ways to figure that out. And if you change your medications, it might improve. Another is, of course, any medical condition that promotes fatigue. An example would be low thyroid levels or other hormones. And that can be diagnosed with a blood test. So I would get a thorough medical evaluation first, make sure that there's no medical cause. And then we could talk about ways to ameliorate fatigue through a standardized activity program, some sort of increased supervised activity that would get you moving and build up your endurance, which is also going to be necessary.
Great recommendations. Thank you. Someone is sharing that they're having a difficult time getting family and friends to understand what they can and can't do from a physical activity perspective, and then it makes them just not want to do anything. How would you recommend that someone talk to their more aware of what their limitations actually are?
Great question. It can be very frustrating when people see you've healed on the outside, but not realize you have a long way to go on the inside. So after any sort of dissection or surgery, as we said, it can take up to a year to fully heal. During that period, you're going to be fatigued more than you were before. You're going to have to work hard to gain back what you lost. And so I would just remind them that it's a real trauma, even if they can't see it on the surface. Your body is still healing, and just like recovering from any illness or visible injury, it's going to take time. And eventually you will get there, but it may not be quite as soon as they think, because it's inside, but it's every bit as real, even though they can't see it.
Thank you. Should folks be monitoring heart rate during exercise, and are there general goal recommendations?
Yes, well, that's a great point. And a lot of people did ask me that in clinic when I started this. So we did pay attention to heart rate. And in our studies, we found that heart rate is not a reliable indicator of blood pressure response to exercise. The reason why we think that is because most people were on beta blockers. Beta blockers slow your heart rate down, but they also slow the rate that it rises during exercise. So the typical heart rate zones you hear about don't apply to people on beta blockers, right? They were made for people who are not taking beta blockers. So you can't just kind of extrapolate them and say, well, I didn't reach 150, so I'm going to be okay, right?
Sure.
You may be maxed out at 130 beats per minute, and that could be very strenuous for you. So what I would say is use something like the Borg scale, which is, again, a very easy to understand scale, where 1 is minimal activity and 10 is the most activity you've ever done in your life. If you can stay in the 4 to 6 range, that's moderate. So on everyone's rating scale, regardless of your heart rate, you can find the 4 to 6 range. And that makes it more universal and easier to translate from one person to another and get them relatively at the same level.
Sure. That sounds great. We'll take one more question, and then we do have to end to move on to another session. But someone's asking, Pilates was previously on the recommended list of exercises for those with connective tissue conditions. Is it still the case in light of the work that you've done?
Yes, I think that the aspect of Pilates that gives most people pause is with the breathing. As long as you're able to regulate your breathing during muscle contraction, that's where we typically see the very high blood pressures, is when you're contracting your muscles and you're holding in your breath at the same time. So there are ways to practice breathing during activities. And I would say that the same holds true for weightlifting or any other kind of muscle intensive exercise. You want to actually practice that or have someone spot you and watch you. You can also do it in a mirror. Mirrors are really good for that. You can watch yourself breathe and make sure that you're not holding your breath, because some people do it subconsciously. You're not thinking about it. You're just, you're bearing down, and that is actually the movement you want to avoid, right? You don't want to do that. So you can actually regulate yourself, but having people there beside you giving you feedback really helps too.
Great suggestion. Many audience who submitted questions, and of course to Dr. Prakash for so thoroughly addressing them and for his wonderful talk. If you have non-urgent medical questions that have not been answered or you'd like more information, please send an email to our Help and Resource Center at marfan.org/ask. Again, thank you, Dr. Prakash, for speaking to our community today, and thank you to our audience for joining us. Have a great
Thanks,
week.
everyone. Bye.